So today we have Patty Cason. Patty is a family nurse practitioner with a specialty in gynecology. She is an assistant clinical professor and guest lecturer at the UCLA School of Nursing. Patty developed the PATH question, and today Patty will share her expertise with us around patient-centered reproductive goals counseling and contraceptive care for special populations. Welcome, Patty, and thank you for being here.
Thank you. Thank you for that lovely introduction. And welcome, everybody. And I do really encourage you to use the chat box and to be able to clarify anything that you're having questions about, and also just to give me your ideas, your sentiment about what we're talking about. I'm curious to hear from you. And we are going to be mostly talking about reproductive goals with some emphasis on contraception care, but that's to be gone into depth at another day. And this is my picture, which is silly because you have my face right here. And here are my disclosures. I am either on the advisory board or consultant or as a trainer for companies that make contraceptives. And these are companies that make IUDs, implant. So, but we're really not going to be talking about anything to do with products today. I do want to talk about the PATH questions. I do want to talk about reproductive goals counseling in general. And I'd love for you to be able to, after this, be actually able to use the PATH questions in your day-to-day practice. There are skills we're going to talk about. Some of them are really things you need to practice, and some of them are things you can just go ahead and use the sentence that I'm going to suggest and just try it. And I really would love for us all to be asking all of our patients about their reproductive goals, regardless of their gender or sexual orientation. And I just think that is going to help us get to better outcomes in general. So let me just put it out to all of you and ask you, what should be the focus of a counseling conversation? So if we want to help somebody clarify their reproductive goals, their desires, their wants, their concerns, what should be the focus of those counseling conversations? So that's just a question to put out to you. And I ask you to sort of ask it of yourself and see where you stand with that. So I'm going to take an approach that comes from a shared decision-making model, which says that, and so this is how I would answer the question, which is essentially I'm there to help the person clarify as well as I can, and as well as they can, what their goals are and what their preferences are about contraception, if they want contraception, or about reproduction in general. So what are their goals, what are their preferences, and how can I help them to clarify what those are? And then my other contribution to the conversation in a reproductive goals conversation, as well as pretty much all conversations I'm having with patients, is about providing accurate information about medicine, about science, in a way that the person is able to actually integrate what it is that I'm telling them. So I feel like I'm responsible for helping them clarify what they want and then help them get it. And part of that involves them becoming more informed than they perhaps were before I met them. And for them to become informed enough about the specific things that they need to know information about so that they can make decisions that are consistent with their own goals and consistent with their own preferences. And what is the patient bringing into a shared decision-making conversation? They're bringing all the good stuff. They're bringing their own preferences, which are often based on their values, their own goals, and very importantly, especially about contraception, but in terms of anything where there's conversations about risk that happen, their past experiences. They are bringing their own lived experiences into every conversation with us. And so when I'm having a conversation with somebody, their past experience is in the room, and it's very important that I address their concerns based on their past experiences, not what I think is probably somebody's concern. So let's just think for a moment about just specifically reproductive goals conversations. What dimensions of people's thoughts, which is different than a feeling, so what dimension of people's thoughts and feelings about reproduction and pregnancy might be important? And this is a curious thing. I find it actually, the more I think about it over these years, the more fascinating I think this is, because in fact, it's a multidimensional concept. Think about for yourself, if you've ever thought about wanting or not wanting to have kids, plans about having kids, an intention about reproduction, a desire for, a particular outcome, which is both a thought and a feeling sort of mixed together, and a feeling, which is really, maybe not consistent with any of the others. Maybe I really, really want a baby, but I'm not planning for one, I'm not intending to have one, and I actually don't want one. But I feel like it would be just amazing to hold that little squishy thing in my arms and give it little kisses. So these are all different concepts, and sometimes someone has all of them that are meaningful and they are all consistent, and much more often some of them are not quite as consistent with the others as others, and sometimes it appears, if you just look at it from a shallow level, like people are having ambivalence, when in fact maybe these things just aren't consistent because they are multidimensional. These are not all the same dimension. Specifically, plans means that there is a decision that you have made, and then you're formulating actions. Okay, so plans are about actions. We're going to talk about plans in a little minute, but plans are something very specific, and I would argue often not a great word to use with patients. Unless the person themselves has said something about their plan, I would probably think about erring towards leaving it out of your conversation. And then there's intentions, which really is more, it's less about action and more about a timing-based idea. So it's my intention that when I am 30, I'm going to have my first child. It's my intention that I be married before I have kids. Sometimes it's about timing in years, and sometimes it's about timing in life events, but it's really more about sort of my general idea of where I want my reproduction to go in the future. So let's think about planning more deeply, because I think it's, for us as healthcare providers and people helping patients with their reproductive and their sexual and reproductive health, I think we often plan. We're all big planners. I don't know about you guys. I plan all the time. So let's think about what that really means. If you're somebody for whom pregnancy planning, in particular, is not a resonant concept for any number of reasons, then why would we really be asking somebody about their plans if that whole concept doesn't really resonate for that person about themselves? And let me just talk about this one study, which was Sonia Barrero's study in 2015. They queried a group of women on a qualitative research study about their feelings, their thoughts, their ideas about pregnancy planning, about having children in general, having babies, getting pregnant. Wonderful qualitative research study. I did include it in your resources if you want to read it. And what they came up with was from this group of women, and I want to say that this group of women was racially mixed and all low income, however. And so what they found pretty consistently was that planning had a definition for these women. And it was a very deliberate act in which both partners discuss and reach consensus about the timing of pregnancy, and they take steps to prepare for a pregnancy, and across the board that included getting your finances in order. Okay, so somebody defines planning, this group actually pretty much consistently defined planning as, I am in a relationship with somebody, we together decide that we're going to have a child, and we have our finances in order before we do that. So unfortunately for the women in this study, while they had very strong feelings about the ideal circumstances under which somebody has a child, specifically that concept of being in a committed relationship and being financially stable, they actually had a judgment that that was the situation in which somebody should plan a pregnancy. Now, that doesn't mean that's the context in which someone should have a child. It's the context in which somebody should plan to have a child. There's a really big difference between those things. So in this case, in this study, few, if any, women actually achieved either relationship or financial stability. And so pregnancy planning for this group of women was irrelevant. It seemed to them irrelevant, because how can I plan? I don't have these things in order that I think I should have in order. Again, that does not mean I can't have children. It just means I can't plan. So when we think about feelings, that's specifically what I was talking about, that feeling inside your body. You don't have to define what it is, but it's that emotion. It may not really have as much to do with your thinking and your intention as you might think. And I'm sure everybody has had situations where your feelings about something weren't necessarily in line with what your intent was. And then desire is sort of a halfway between, and there's interesting data on this, it's halfway between a thought and a feeling. Or it's maybe a little bit of a cluster. You have thoughts and feelings and you get desire. So it's about strength of inclination to either get pregnant or avoid pregnancy or prevent pregnancy if you're not the person actually getting pregnant. If you're not the person getting pregnant, then it would also be your strength of inclination about causing pregnancy or avoiding causing pregnancy. Now, the reason I have acceptability in much bigger font is that at the end of the day, that's what it starts to come down to for a lot of people. It's about after the fact, now I am pregnant. And so now I'm going to make the decision, is this acceptable? So maybe I want that baby. Maybe I want to have that pregnancy continue and I want to have a baby, but I can't. Okay, so my ability to do it is not there, so it's not acceptable. It's not an acceptable pregnancy because I can't manifest it for whatever reason, financially, personally, whatever reason. I want it, I can't have it. So they're not in line with each other, but at the end of the day, the trump card is acceptability. That's going to be the thing that's going to be the decider once the person is pregnant. Now, we don't want somebody to have to get to a point where they are making a decision about a pregnancy that they don't want, is not acceptable, that they never intended, and that they're clearly just negative about from beginning to end. We don't want that for our patients. We want to help them get what they want. And so helping somebody get what they want is helping them to get pregnant when they want to get pregnant and not be pregnant if they don't want to be pregnant. Not cause pregnancy when they don't want to cause pregnancy, and cause pregnancy when they want to cause pregnancy. So because, and this is directly out of Sonia's study, because what they found was that because the intention preconceptionally and the planning don't necessarily occur, the decisions about acceptability of pregnancy are often determined after the pregnancy has already occurred. And interestingly, and I'm sure everybody knows this from your personal work, many women express happiness with a pregnancy regardless of intention. Now, that's kind of a big old duh, but I think when we all get very caught up in the concept of unintended pregnancies are bad, and unplanned pregnancies are bad, and planned pregnancies are good, I think we sometimes lose sight of the fact that you can be very happy about a pregnancy that you didn't necessarily intend, and it can have a very happy outcome also. So what Sonia's conclusion was is that the current conceptual framework that we're really steeped in, that views pregnancy-related behaviors from a planned behavior perspective, may be limited among low-income populations. And I would argue it may be limited among many women, and many people. And I don't think that's necessarily only people who are low-income. I think it's really individuals. All of this that we're talking about today is trying to underline the idea that each of our patients is an individual. Each of the people we interact with has their own story, their own lived experiences. And so many people may not, the concept of planning a pregnancy may not resonate for many people. There may be many people who think, if it happens, it happens, it's not in my hands, for a variety of reasons. You could probably all come up with at least 10. I do want to introduce just one concept, which is stratified reproduction. The reason I want to bring this word up is that, first of all, I think a lot of people don't think of it this way. You probably know this, but you probably don't think about it. But the word stratified reproduction specifically means that there is a different value placed on the reproduction of some people than the value we place on the reproduction of others. So we all talk about we want to optimize birth intervals, right? We're all about, we'd like to have that nice 18-month break between two pregnancies, right? Between a birth and another pregnancy. And that's all well and good, but when a princess gets pregnant, when a princess has a child, what's the first question? Ask yourself, what's the first question people ask that princess and prince? Do they ask them, are you going to have an 18-month ideal spacing between your pregnancies, or are they going to say, when is the next one coming? Because this is valued reproduction. So ask yourself, how comfortable are you talking with sexual minorities about childbearing? So a sexual minority is somebody who is not exclusively heterosexual. So think about, or somebody who's got a gender other than the gender they were born with. If I am a cisgendered woman, which means that I was born given a female identification, and I identify as a woman, and so I am a cisgendered female. So if I were not, let's say I had been born a male, I was identified as a male, I was given that label at birth, but this is how I'm now presenting and I'm a female, then I would be a sexual minority. If I were somebody that wasn't exclusively heterosexual, I would be a sexual minority. So that's what that means. So I'm asking you to think just for yourself how comfortable you are talking about childbearing, about having babies, about having children with people who are sexual minorities. And then what about people who live in poverty? What are your thoughts about that? What are your feelings about that? And underlying all of that, really, what are your beliefs about people who live in poverty having children, even if their finances aren't in order? So now we're going to talk about specifically how you get to have these conversations in what we expect to be an efficient way, and I want to underline that. We're going to talk now about discussing and engaging with patients about their reproductive goals in ways that may seem to you like they are going to take time. And I want to reassure you that this is not a big waste of time. This is actually asking questions in such a way that you can get answers that are very appropriate to the conversation you are having that day. So it's going to get you the information you need to be able to offer the kinds of services that the person needs that day or wants that day. So like we're saying here, these are questions that are efficiently designed to clarify the person's motivation and degree of acceptability. Remember, we were talking about how important that concept of acceptability is. But we're talking about helping them clarify the degree of acceptability about pregnancy before they get pregnant, if they're a person who can conceive, or before they cause pregnancy, if there's somebody who can cause pregnancy. And the reason for that is so that we can offer appropriate interventions. Obviously, if somebody says that they would like to have, that they never want to have any children, you probably, it's a very different conversation than if somebody says they're planning right now to have a child or they've been trying already. Because we want to offer preconception care conversations if the person's at risk of pregnancy for whatever reason, or if they've stated that they're open to pregnancy. So either one of those two things will bring somebody to having an offering of a conversation about preconception care. Contraception, if somebody says that they would like to get pregnant now, we don't offer conversations about contraception, of course, because all this is about listening. You ask these very simple questions, but the real trick is in the listening to the answers. And then maybe the person, really what's most appropriate after you've asked about these reproductive goals is to help them with fertility struggles or with adoption. The questions that we're going to go through, which are the PATH questions, are designed for everyone of any age, any gender, any sexual orientation, and hopefully our hope is that it's not stigmatizing someone struggling with infertility. That if somebody is struggling with infertility and they're asked about, would you like to be pregnant, it's a little bit off-putting. Sometimes it can feel hard. And so we're hoping that the PATH questions are going to not make the person feel stigmatized in that way. So here's what they are, and they're an acronym. The PA stands for parenting or pregnancy, depending on which P you want to focus on, pregnancy or parenting attitudes. So PA, pregnancy or parenting attitudes. And it's a very simple question. Do you think you might like to have children at some point? If the person already has kids, you say, do you think you might like to have more children at some point? Just a very simple question. I would, if you're going to practice this, and I would love it if you would, I would not leave off the do you think you might part. I wouldn't just start with, do you want to have children at some point? It's a little softener to say, do you think? It's also giving the person just a little moment to consider the question. It's giving them a moment to think, well, maybe I've never thought about this before. And one of the beautiful things about this is that you're going to be having an opportunity to ask patients questions about their goals, and they may never have actually been asked those questions before in their life. They may never have even asked themselves that question before. So it's nice to give them a moment, and it's really not more than a beat or two. We're not talking about more than seconds, to think about whether they would like to have children or whether they'd like to have more children. And then the second question, and these are not all asked of all people. Okay, this is the 3 potential questions. Sometimes you stop after 1. Sometimes you stop after 2. Sometimes you skip the center one, the timing-based question. And I'm going to give you lots of examples. But don't think of these as 3 questions. Think of them as 3 possible questions. So the second one, the T stands for timing, in case you're trying to remember it. And that's just when do you think that might be. we really encourage you not to ask a person about when they'd like to have children unless you've already established that they would like to have children or more children. So you don't assume that they want children. And then the last question is H for how important. And so it's a follow-on question about how important is it to you to prevent pregnancy. And so if the person hasn't told you anything else and you don't know more information, then you say how important is it to you to prevent pregnancy until then. But clearly you're not going to say until then unless the person has said, yes, at some point I would. Because if they don't want to have children at some point or more children at some point, you wouldn't say until then. So you can get the point that we're talking about something where you have to listen for the answers. Very simple questions. They elicit wonderful information very efficiently that you need to know, really, if you're going to be trying to align the services you're offering with the things that the person needs. But the trick is in the listening to the answers. So let's look at some examples of this. I want to make one point, though, that is not going to be made in some of the examples I'm going to give you, which is the T part of this, the timing-based question. It's only there to differentiate people that are currently trying to get pregnant or have been trying, or are just open to it, and what happens happens, but they're not doing anything to prevent it. It's to separate those people so that you can offer a preconception care conversation from everybody else. So that's the really main reason. But the other main reason, there's two. The other is to help the person to think more about their reproductive goals, to think more about their life going forward. Not about the guy they slept with last night or the guy they broke up with last week, but to think about their life going forward and where having children or not having children might fit into that. What this T, timing-based question, is not about is to try to help you determine which contraceptive method is best for the person. Because if the person says that they don't want to get pregnant anytime soon, trying to narrow it down to, is it 2 years, 1 year, 3 years, 5 years, so that I can match the birth control method, I would urge you to not think about matching that in any way. If the person is interested in a method that could potentially be long-acting, then it's good for up to that number of years. But if they want it out for any reason or they want to get pregnant before that length of use, they come in, we take it out, and their ability to get pregnant goes back to whatever's normal for them immediately. And so it doesn't matter whether they had a plan for, they had talked about 3 years versus 2 years versus 5 years. Any of them can be used longer if they want to by just getting another one put in, or can be used for as short a time as they like. They can come in the next month and say, okay, I changed my mind, I want to have a baby, and their fertility is immediately returned once you take it out. So just try to, it's a real trap to try to think about the timing-based question as having something to do with contraception. That last question, H, how important is it to you to prevent pregnancy? That's a question that does relate to contraception, because if the person says, not very important to me, then obviously the effectiveness of their birth control may not be one of the things that they're looking for in contraception. Effectiveness may not be that important to them. So as opposed to somebody says, when you say, how important is it to you to prevent pregnancy? And they say, oh my goodness, that's the most important thing to me. Then when you're rephrasing back to them later in the conversation, since you've said that it's really important to you not to get pregnant until you're out of school, or not to get pregnant until you're married, or whatever they've said, then you can go directly into a conversation about effectiveness of birth control. So let's look at some examples. Do you think you might like to have children someday? And she says, yes, I definitely want to be a parent someday. And you're going to also notice perhaps her body language is open, and she's leaning forward, and she seems excited about this. And she says, I'm pretty traditional, and family is one of the most important things in my life, but I definitely want to be married first, which I don't see happening anytime soon. So if we were in a group where I could get answers from you, I would ask you, do I have to ask a timing-based question here? She's already said that she doesn't think that this is going to happen anytime soon. And that's really all you need. For a timing-based question, you're sort of, is this something that you want to talk about for anytime soon, or is this no time soon? She's already said it's no time soon. So I would say, save your time, skip the timing-based question, go directly to asking, how important is it to you to prevent pregnancy until then? Or, better, how important is it to you to prevent pregnancy until you're married? Because she has already said her timing-based concern is marriage. So how important is it to you to prevent pregnancy until you're married? So what about if the person said, in answer to the first question, let's just say a generic yes, but they didn't say anything like our prior patient did about timing. So then you would ask a timing-based question. So if they say yes to the first question, yes, I would like to be a parent someday, you say, when do you think that might be? And any answer that they give you that indicates no time soon, you go to the last question, which is how important is it to you to prevent pregnancy? Let's look at that last question, because it's quite important. You see that I have that little until then in the parentheses. So how do you individualize the question? I would urge you to individualize the questions in whatever way you feel like you can, based on the information that you've gleaned, because you know the patient, or you listen to the patient, or you have been watching how the patient's reacting. Okay, so you're going to use the information that you have about that patient to individualize the question. So for example, how important is it to you to prevent pregnancy until you're out of school? As the person said, yeah, I definitely don't want to get pregnant until I'm out of school. Or how important is it to you to prevent pregnancy until your partner gets back? The person has just said, it's incredibly important for me not to get pregnant until my husband gets out of prison. Now, that may only be in 6 months, but that may be somebody who needs a highly effective method because it's quite important to them not to get pregnant for this period of time. Individualized. Maybe the person was very concrete about years, and you say, do you think you'd like to have children at some point? And they say, yes. Do you think that might be 5 years? And then you say, how important is it to you to prevent pregnancy for the next 5 years? So when do we use the term until then? We use it for teens or if we have no other information. So the person said, you say, do you think you might like to have children at some point? And the person says, yes, absolutely. And you say, when do you think that might be? And they say, yeah, no time soon, which is fine because that's all you really need to know. And then you would say, how important is it to you to prevent pregnancy until then? The only time you wouldn't use it until then would be if they said no, right? Because until then means that they do want to have kids at some point. So specifically for adolescents, how do the PATH questions really work? And are there differences in how you might use the PATH questions? So I'm going to suggest when you are thinking about adapting PATH questions for adolescents, first ask yourself how you feel about adolescent sexuality and what are your beliefs about that? Because you're going to be potentially interacting with people who are sexually active or having sex, and it's important for you to understand what your feelings and beliefs are about that, so that when you're interacting, you're not, without being conscious of it, having your beliefs about it actually spill over into conversation. So you should be really clear about what your own feelings and beliefs are. And then to try to do whatever you can to become comfortable if you're not already, or continue becoming more comfortable if you are comfortable. So I would say you can go straight from, do you think you might like to have children someday, which is a great opener because they start thinking about their future, which is always a wonderful thing to do with a concrete adolescent who's thinking about right now. So thinking about the future is a great way for them to do that. And then just directly to how important is it to you to prevent pregnancy until then. So if they said yes, then you say until then, but if they say no, then you don't say until then. Do you think you might like to have children someday? Oh, no, 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 no. How important is it to you to prevent pregnancy? Okay, you don't have to get in why they said no. That's not relevant to the conversation today. If you want to have an efficient conversation with somebody that's going to lead to an eventual outcome of that visit that day, the outcome being they are going to hopefully walk out of the interaction with you with either a birth control method that's consistent with their preferences or preconception care information, prescription for folic acid, something that's consistent with what they want. If that's your goal, don't get sidetracked into conversations that are not relevant. It's not relevant why this adolescent. It's not relevant why the adolescent said that they don't want to have children someday, right? It might be very interesting. It might lead you to get a lot of information about the person. But really today, what we want to do is have this conversation about reproductive goals and potentially either contraception, preconception care, or both. So what about somebody who says no to the first question? Do you think you might like to have more? Do you think you might like to have more children at some point? And the person says, absolutely not. I am done. Done. So they'll show you with their face, with their body language, with their face. Maybe they'll pull back, their tone of voice. And so, do you ask a timing-based question? The person just said no. So of course you do not ask a timing-based question. Could you imagine how that might damage rapport if you say, do you think you might like to have children at some point? And the person says, no, I'm done, done. And you say, well, when do you think that might be? So you can see how this is not 3 questions. It's 3 potential questions. So am I going to say until then for this person? No, I'm going to take out the until then, and I'm just going to say how important is it to prevent pregnancy. So for a no answer, there's only one simple question. So what about if the person says, I'm trying? Or we want to start trying, or I'm totally open to pregnancy anytime, whatever, it's fine. The person says something to do with now, so let's say they say, yes, we've been actually trying for a while. So obviously you do not ask a timing-based question. Definitely do not ask how important is it to you to prevent pregnancy, because that would be really silly. But you would ask a preconception care conversation. So would you like to discuss ways to be prepared for a healthy pregnancy? Now you see we're not having the word plan in there. So I would urge you, if you're going to offer preconception care conversations, not to just launch right into here, take this prescription for folic acid, but to actually ask and get a little bit of an agreement so that the person knows that we're now going to have a conversation about being prepared for a healthy pregnancy. And I would also not use the word plan. I would say to be prepared for a healthy pregnancy, just based on all the reasons that I gave you earlier. So there's other times when you would use the same phrase, and it would be if, so this last person said that they're trying, right? And this next person says, well, if it happens, it happens. So then you would say, since you've said if it happens, it happens, would you like to discuss ways to be prepared for a healthy pregnancy? Or how about the person that says, I'm using withdrawal. He takes care of me, and that's their birth control, and they're not going to change their birth control method. You might say, since many people using this method get pregnant, are you interested in discussing ways to be prepared for a healthy pregnancy? Sometimes that can be a wake-up call to let them understand that that effectiveness is not all the same for all methods, but it's also, if they do get pregnant with withdrawal, I would like them to have had a preconception care conversation. I don't have a judgment about it, but I would like to be able to have them have the full force of medical knowledge in 2018, which means that it's better if they are taking folic acid before they conceive. So if somebody's using a method that is not very effective, a preconception care conversation being offered is a wonderful option. Let's look at a couple of specific people. So SEMILLA is, she's been pregnant 4 times. She's had 2 kids. She's 33. Her BMI is 42. And she has diabetes, and her hemoglobin A1C is 12. So I'm just going to suggest ways that you can individualize some of the questions. So for the timing-based question, you would start with a little bit of information and then follow it with a question. Now that's a generalizable principle. Give a piece of information, ask a question. A piece of information, ask a question. It's called an information sandwich. Sandwich the information between questions. So I'm going to talk about that in a few minutes again, but I just wanted to show you how it's happening here. It's important for people with diabetes to be prepared for a healthy pregnancy by getting their blood sugars in good control and making sure they're on the right medicines before they get pregnant. So you've said you'd love to have another child at some point. Do you think you might like to get pregnant soon? This is a totally individualized question. You wouldn't want to memorize this. You would want to just understand that in a very few number of words, I've been able to reflect back to the person what it is that they've already shared with me about their goals, as well as giving them information. And hopefully my asking of the question after the information means that the person integrates the information. And I want that person, I want SEMILLA to know that it is better, in terms of her desire for a healthy pregnancy, for her to have her sugars under control. So paraphrasing is kind of the heart and soul of counseling skills. And it's hard to do, but it's worth it, worth it, worth it. And it's about rephrasing back to the person the gist of what they have said, or summarizing some of the points of what they've said, or maybe it's just highlighting one thing they've said that you think is important for the conversation. Things like, you will start it by saying, I'm hearing you say. So in other words, you warn the person, I'm about to paraphrase. I'm hearing you say that you'd really like to wait until you finish school to think about having a baby. And then, with all paraphrasing, the structure of it is you ask a confirmatory question, something like, do I have that right? And so the person says, yes, at least 5 years. I also want to have some time to start my career. It sounds like you put a lot of thought into your future. How important would you say it is for you to prevent pregnancy until you finish school? So again, this is individualized, the last question about how important. And how I'm individualizing is I'm not only letting the person know I heard what they just said by rephrasing, but I'm also acknowledging, validating that the person has put a lot of thought into it. So I'm using a positive as an anchor, and then I am asking the question. Brandon is age 23. He's a cis male, and so remember what that means is he was born a male, and he was identified as a male at birth, and he now identifies as a male. And Brandon absolutely does not want to cause pregnancy anytime soon. So I'm going to paraphrase for Brandon, and I'm going to say it sounds like it's very important to you right now that your partner doesn't get pregnant because you want to be able to decide for yourself about being a dad or not. Because Brandon had said, I don't know if I ever want to have kids, but I know I don't want to have kids anytime soon. And he's with somebody that he could potentially cause a pregnancy with. And then I would say, again, my follow-up little confirmatory question, is that what you mean? Other alternatives that I would recommend using liberally, many of my patients say that, and then fill in the blank. Is that what you mean? You're not paraphrasing. You're guessing based on everything you know about the person, about what they may be thinking, feeling, what they may be objecting to, what they may be concerned about. Perhaps the person thinks that birth control messes with their fertility, just like many, many, many of our patients do. It's a big misconception that contraception messes with fertility. So many of my patients say that they're concerned if they use contraception that their ability to get pregnant will be affected, that it will be bad for your ability to get pregnant, or I might say, many of my clients say that they're concerned that birth control messes with their ability to have a baby, because I want to use patient-centered language. And then I would say, is that what you mean? So I'm not putting words in the person's mouth. I'm not saying, so I'm hearing you say, because the person didn't say it. Another thing you can do is just go purely on an emotional signal. So the person has shown you, expressed verbally, a strong emotion of some kind. So you could say, so you feel pretty strongly about da-da-da-da-da. Is that accurate? And when you're listening, it's really important to also pick up the information that they're giving you by their tone of voice and body language and facial expression. So this particular woman, she says, yeah, I think I want to have kids someday. So she's already like someday. So she's pulling back her body, she's holding her arms up to protect herself, as opposed to, yes, I'd love to be a mom. So that information is very important as well. Don't forget to look at that. If this particular woman had been having her face light up with a grin and she's leaning forward, that might actually be telling you that the idea of becoming a parent is joyful, as opposed to that this person isn't really quite so sure about whether she wants to have kids. And Sam has never been pregnant. Sam is age 22. He's a trans man, and his pronouns are he, him, and his. He has type 1 diabetes, and he has had type 1 diabetes since age 6. His current partner is a cis gay male, so cis male meaning the person was born male and is now identifying as male and is gay. And Sam is in the office, not for contraception, but for genital warts. So let me ask you if you would ask the path questions of Sam. Now, Sam is a man. I've already said everybody, all genders, all sexual orientations, we want to ask these questions. So specifically, would you ask the path questions of Sam if he had said he was unpartnered? So you're having a trans man who's unpartnered. Would you ask the path questions? I would argue that it would be a great idea. Sexual minorities are at higher risk for pregnancies that they do not want than people who define as exclusively heterosexual. So also, what about if Sam's a trans man and he's in a gay relationship right now, but what if he were not? What if he was only having sex with women? He is exclusively heterosexual. Then would you talk to him about the path questions? Would you ask him about his reproductive goals? And again, I would argue that it would be a good idea. because people don't always partner exclusively with the same people that they've been partnering exclusively with in the future. But also, I want to help Sam potentially have kids if that's what Sam wants, or help Sam not have kids if Sam doesn't want kids. Additional questions, always whenever you think that it will be more resonant for the person to ask about feelings, that's a great thing to substitute. How would you feel if you became pregnant now, or how would you feel if you caused a pregnancy now? The reason that it's a different question, but for some people, giving them that concrete, put yourself in this situation and see how it makes you feel. That's a very helpful thing for some people. And then giving it a timing context is also really helpful for some people, depending on how their brains work. How would it be for you if you became pregnant or caused a pregnancy over the next few months? Okay, so it's sort of a wider range than just the now. And then asking specifically about either finances or health or family or interpersonal relationships, jobs, schooling, children, their own parents, any of this context. So if you were to become pregnant, do you have a sense of how it would affect your fill in the blank? And these are all things, you don't ask this of everybody. You don't even have to ask it really of anybody. But if you're going to ask more or different questions because of the particular individual you're talking to, these are some of the things you might want to bring up. How ready are you is a wonderful resonant concept for some people. How ready are you to become a parent? And for somebody with health issues, do you have a sense that you'll be able to maintain your health during pregnancy? And see how this is not saying to them, I'm the care provider, I'm going to make you healthy, you're going to do what I say so that you will then be the epitome of health because I've told you what to do. It's really giving the person control over their own body and life. Do they have a sense that they'll be able to maintain their health during pregnancy? What are your thoughts about your situation, financially or in some other thing you could say? But financially is obviously a big one, in regard to having a child. Again, not for everybody. This is a very specific question for a very specific individual. And is your health condition, whatever it is, stable? And then I think it's a great idea to at least consider, in some cases, asking about partners. So do you have a sense of how your partner would be with the idea of starting a family, or in the case of someone who has children, having another child? So rather than so let's talk about empathy. These are some skills that I'm going to run through. Empathy is a critically important skill, and it's very simple, actually, is to notice that somebody has a negative feeling of some kind, and then just use a neutral word like, it sounds like this is really concerning to you, or something that's really validating by saying, wow, anyone would find that really hard to deal with. So what you wouldn't want to say is, wow, you seem really angry or anxious, because maybe your definition of anxious and theirs is utterly different. And so you don't want to label it, and you also don't want to say, I know how you feel, because invariably they will say, no, you don't. You do want to get the level right, though. You don't want to, if the person says, I find it really hard to remember to take the pill, you don't want to say, wow, I can see how that was incredibly difficult for you to deal with. I mean, I'm exaggerating, but you don't want to get the level wrong. The person says, essentially, that they're suicidal, and you say, well, that sounds hard, that sounds difficult. So finding the yes is not the easiest skill, but it's certainly is going to help you to build rapport and to be more efficient in the room, as well as to just have increased patient satisfaction. And the first step is to find something in what the person is saying to either agree with or support. So when you find yourself about to correct your patient or disagree with your patient, and this is pretty across the board, if you find yourself about to do that, take a step back and think, is there some kernel of truth in what they're saying that I can agree with first and then add the science? Or if not, if everything they're saying is completely with no basis in reality, is there something I can empathize with about what they're feeling about this? Or can I just validate something that they have done positively that I can point out and then build my science into it? And misinformation or misconceptions, some of the things that you might want to correct, people have across the board, it seems, lack of understanding about the relative effectiveness. So, you know, we have these nice tiered effectiveness charts with the top tier, less than 1% failure, and the second tier, and the third tier. A lot of our patients think birth control methods are all relatively similar in effectiveness. They also underestimate their own or their partner's fertility. very commonly believe pregnancy is safer than contraception. So these are some of the misconceptions or misinformation. There's many, many, many others. And so you will be very, you'll be more successful if you start by saying yes and then you give your science. You don't correct it, you just then give the correct science. So agreement is always the best if you can, because they've given you a fact that's wrong, but if you can find a little fact in there that's right, you can pull that out, add your science, and then the new fact base is all right. Or if you can't, find something to agree with. I can see that that's really hard for you to deal with. Or, wow, that sounds like it was concerning to you. Or validation. Let's look at some examples with Emma, who's 16. And she said, I've had sex without using anything for a while now, at least 3 weeks, and I haven't gotten pregnant, so I doubt it's even possible. So I could say, I could give my pathophysiology lecture about how she is at the height of her fertility, and nobody could be more fertile, and just because she hasn't gotten pregnant yet doesn't mean she won't, because she will. I mean, that's what I want to say, right? That's what we all want to say, but none of that works, so especially not with a teen. So I'm going to either do a display of empathy, I'm going to validate, or I'm going to agree. Okay, so I could either give her, now I said agreement is always the first choice, but there's not much I can agree with Emma. So a display of empathy, it seems like that's concerning to you. Okay, so that's where I'm starting. Or validation. Yeah, you know, I hear that a lot. Many of my patients say that. Or agreement. I can see how you would think that. And then add the science. And now I'm going to give you a follow-up to the PATH questions, which is the single best contraception counseling question. Do you have a sense of what's important to you in your birth control? Just memorize that question and ask it all day long, and you will have a very efficient conversation around contraception, because there's many different characteristics in different contraceptive methods, and this is an attempt to get as much information about what the person's interested in with preferences about those characteristics as possible in a quick way. This is the information sandwich I talked about. You're going to ask a question, then give information, and then follow it with a question. And these are the follow-up questions that you want to consider using. This helps the person integrate the information you've given them. If you give them a piece of information, then another piece, then another piece, then another piece, you'd be lucky if they remember one or two of them. So assume they're only going to take in one or two at a time. Give them one or two pieces of information at most. How would that be for you? Many women using this method either don't have any bleeding at all, or they only have occasional bleeding or light spotting. How would it be for you if you didn't get your period while you use this method? About 1 in 4 women or 1 in 5 women have frequent bleeding with this method at some points in time, or prolonged bleeding. Has that ever happened to you before? Yes, it happened to me when I used blah-de-blah. How did you manage it? So those 3 questions. Use them all liberally all the time. And then the last question is just, if the person hadn't had that experience before, you'd ask them to imagine how they might manage it if that were to happen. There's lots of obstacles to somebody being able to have their goal and their behavior in line. I have a goal about my reproduction and maybe need for contraception so that I can get to my goal, and then I have the behavior. I definitely do not want to be pregnant until I'm out of school, and I just had unprotected sex last night and last week. Goals, behaviors, they're not aligned. So in this case, if you say to the person a type of paraphrase, which is just on the one hand is the goal, and you describe the goal, and on the other hand is the behavior, and you describe the behavior, and it helps to actually show the patient. Anytime you can do a visual with counseling is better than if you're just using your words. So it's on the one hand, on the other hand. Once you have found the obstacle, once the person's told you what the obstacle is, you put the goal on one hand and the obstacle on the other. And the point is for them to see them in a very neutral way so that they can actually take the next step about maybe resolving this discrepancy. So I would ask you again, this is another question for you, is how do you react when confronted with a client situation that doesn't fit your expectations? So that person who says, it's very important for me not to get pregnant, I just had unprotected sex. Does the situation provoke feelings of anxiety and discomfort in you? If so, pay attention to that, because that's very important information for you. Just like you walk in the room and you smell smoke. That person's a smoker. You walk in the room at 10 in the morning and there's alcohol on the person's breath. That's giving you information. This is the same kind of feelings that you have. These are just a couple of examples. On the one hand, you're saying it's very important to wait until you're ready. Then on the other hand, and this is the obstacle, on the other hand, a part of you would like to have a baby now. Do I have that right? On the one hand, you'd really like to finish school before you become a parent, and on the other hand, it's hard to be consistent with your birth control. That's the obstacle, on the other hand. And you must pause for a reply and not resolve the discrepancy yourself. Your job is to show this so they get to choose. And maybe that is that the person's ambivalent, and it may look like ambivalence, but maybe the person is just trying to hold on to their mate. And so they're sort of conflicted about getting pregnant because they know that that's what the partner wants. Maybe they just want to be reassured that they're fertile. This is a very common reason somebody might be not consistent with contraception. There may be logistical issues or misinformation. And I want to close here by just giving you this visual. If you can see on the y-axis, the desire to become pregnant, if it's very strong, and then the desire to avoid pregnancy is also very strong, that's where we get ambivalence. But if your desire to become pregnant is really very low, and your desire to avoid pregnancy is really very low, you're just indifferent. These are not the same thing. People may move within these in the course of a day or a month or their lifetime. Well, of course they do within their lifetime. But just these are not static, but it is interesting. So in general, talk less, ask more questions, and above all else, listen to the answers. So now I'm going to ask, rather than saying, do you have any questions, which would mean that everybody would be very silent, walk out of the room, which is what would happen with a patient. If I said, do you have any questions, they think, oh, if I'm a dummy, I'm going to ask a question. So instead, I'm going to ask you, what questions do you have? Do we have any?
None on the chat box, but we can give them a second. Is there any from the room?
And I'm sorry I ran into your Q&A time a little bit, so apologies.
They can also unmute themselves if you want.
Can you unmute yourself? Oh, we are going to unmute them?
They can, yeah. If you have a question that you'd like to verbalize, you can feel free to unmute yourself and ask it.
Here I'm showing, this is my email address, but that's also a website, envisionsrh.com, and you can go get a lot of great information on that website. It's all free for you to use. Anything on there you can take and use. It's all in the public domain. You don't have to credit me or anything. Do we have a question?
Question from the room?
Caitlin,
yeah. Hi.
Hi. How would you tweak the past question if, say, this were in the abortion context? Do you have any other sensitizing pre-questions, or how would that shape the conversation?
Yeah, I think that you have to feel it out when it's in an abortion setting, because I think it's important from the data that we have and also just our own intuitive sense when we're interacting with patients. It's really important to see what level of receptivity or interest the person has. Some people are just not interested in having that conversation, and this is not a substitute way to have a conversation the person doesn't want to have. I don't have a particular way that you need to sensitize the questions, because the questions are meant to be individualized, first of all, but more importantly, they're so sort of basic and broad that there's no need to individualize those. I mean, there's no need to sensitize the questions. I would start with the first question, clearly, to just acknowledge that this pregnancy was not a pregnancy that was acceptable, obviously, according to that. I wouldn't use the word acceptable, but I would acknowledge that they're here to terminate a pregnancy, and just say, at some point, you think you might like to have children. So it's taking it away from pregnancy. It's taking it away from unintended pregnancy. It's just talking about the goals for the future. And I think that that's a perfectly reasonable thing to do in the setting of somebody who's receptive. But you got to pay attention. I could, if we don't get any questions, I can tell you guys how to prevent a vasovagal. You want to have some value here. The other thing I just want to point out that the question that I told you, do you have a sense of what's important to you about your birth control? It really allows the person to describe and differentiate some of the characteristics, some of the preferences that they have. And in only about 85% of the cases is one of the things they're looking for going to be highly effective or effective. So that whole concept of tiered effectiveness and everybody should have an implant or an IUD, I think we need to jettison that whole concept and think that what we really want to do is match the person's preferences. to the goal, the preferences and goals to the method that's most likely going to suit those preferences and goals. That's I think, the change in paradigm I'd like to encourage. Do you have any other questions for the chatty bunch, aren't you?
Someone has asked, are there IUD medical trials at this moment in Utah? I think that's the interpretation of this question.
Yes.
Yes, there are.
Yes, there are.
Sorry.
We can definitely run people to here.
So the question was about medical trials for IUDs in Utah.
Somebody's coming to give you an answer.
And
Mine is yes.
And the answer is yes. And if you are interested in having something to refer patients to, or if you're interested in learning more about the different trials that we are doing at the University of Utah, we could definitely send some of that information out in the follow-up email or at a subsequent time. To give you a sense of some of the work that we're doing right now, Dr. Turok, who I believe you met in the first session, is currently conducting a non-inferiority trial comparing copper IUD to a levonorgestrel IUD for emergency contraception. We're following women over the course of a year to see what their outcomes are in terms of pregnancy. There's a few other studies that we're doing with respect to different IUDs, and there's too many of them to go into in detail, but if you are interested, feel free to reach out and we can give you some info on how to follow up on that.
Interested in information for patients specifically.
Yeah, we can also provide the information for our study team. So we're constantly recruiting people for different studies, and if you'd like to have something to give your patients, if they're interested in participating in trials or they want to try something out, we can definitely provide you that information. I can get the contact information for how to get in contact with our study team.
Great.
Any other questions? Thank you, Patty, and thank you everyone for joining us today. You'll receive an email from me very shortly. Please complete your post-test, and we'll see you here again next week.